So, good evening, everyone. It's 6 p.m. Bahrain time and 5 p.m. Cairo time. We have changed the timing based on many requests, especially from Dr. Tariqan. I hope Dr. Tariqan will be able to join us today. He's already here. Is my screen clear? I'm sharing my screen.
دكتور بس.
Okay. So, to go without delay, we finished the ovarian cancer module. It was a small module or a mini module, like what I say. And then we will go rapidly through endometrial and cervical cancer, and then we'll have like miscellaneous and according to your requests after that, according to what you want, yani. So this is one of the most important presentation really. When I was finishing it, I really was thinking, because this is something, endometrial cancer, we are facing many cases of endometrial cancers in Bahrain. It's the most common Is my voice clear? Yes. Okay. And Dr. Ala, you raise your hands. We haven't started yet, Dr. Ala. I'll just open for you. You are allowed to talk, Dr. Ala, of course. اوكي.
منور، ما شاء الله عليك.
ربنا يخليك دكتور علاء، ربنا يخلي حضرتك.
قمر
So
زي العادة، قمر زي العادة.
thanks, special.
اتفضل.
So
اتفضل.
those are my disclosure of interest. And again, endometrial cancer looks like the Cinderella story of gynecological cancers. It's the easiest cancer. The most common cancer is endometrial cancer. And for many people, it's just an easy surgery. You do a hysterectomy and that's all. And really, this is, simple hysterectomy is enough in many cases of endometrial cancer with more or less a good prognosis. It has one of the best prognosis all over the cancers, all over the body, not only gynecological cancers, but it has one of the best prognosis ever, especially type 1 endometrial cancers. And it's much better than ovarian cancer, for example. Maybe equal to early cervical cancer, which we don't see, but we do see many cases of endometrial cancer. With less and less systemic treatment, especially in early stages. With early stages, you don't have to give chemo, you don't have it's like surveillance, nothing at all. You don't give radiation. You give radiation sometimes for the intermediate risk, and then you have to give chemo and radiation in some types, and then immune. But in the vast majority of endometrial cancer, which is type 1 endometrioid adenocarcinoma grade 1 or 2, stage 1, early stage, it's just hysterectomy, as if you are dealing with fibroids, with adenomyosis, with atypical hyperplasia, with anything of this. However, there are two sides of every story. This is something that makes endometrial cancer easy and lovely to all general gynecologists, as I see, and even surgical oncologists. It's an easy, just I'm going to do a hysterectomy. This turned out to be the cause of many sad stories when the management is suboptimal. When you manage cases with hysterectomy, hysterectomy is not enough for that cases, or even with subtotal hysterectomy sometimes. So making it that easy makes many people who are, like we say, يجرأوا to go and do hysterectomy. For example, I know many gynecologists who are not going to put a hand in a case of ovarian cancer, who are not going to manage cervical cancer because they can't do radical hysterectomy. However, for endometrial cancer, we are going to do a simple hysterectomy, and that's all. So let's go to a real case scenario that we see several times in Egypt and in Bahrain and everywhere. She's a 63 years old female, presented with postmenopausal bleeding, generally fit. Her performance status 0. Performance status 0 means she is very fit and she is a slim patient. And the TVS showed endometrial mass, highly suspicious for endometrial cancer. So she came to you in the clinic and you did a bedside ultrasound. You find an endometrial mass which looks like highly suspicious for endometrial cancer. And the patient is fit, she is slim, she is postmenopausal, so there is no concerns about fertility or about ovaries preservation or anything. And then you proceeded to open total abdominal hysterectomy plus bilateral salpingioophorectomy. You did that, and then the postoperative pathology turned out to be serous endometrial cancer, and then you put the case in the National Tumor Board for discussion. now you are very satisfied. I have done hysterectomy. The pathology turned out to be serous endometrial carcinoma. I finished my job. I'm going to put the case on National Tumor Board. And then, could we have done better for this case? Now I am open to your discussion, to anyone from the audience who can raise her hand or his or her hand or want to answer. Could we do something better for that case? Anyone from the participants wants to say something or to add something?
She underwent hysterectomy without DNC biopsy.
Yes, just the ultrasound was endometrial mass. She has bleeding postmenopausal, and so she didn't have a biopsy. The postoperative turned out to be serous endometrial carcinoma, so it was endometrial cancer.
So first, we have to do biopsy for every patient with post-menopausal bleeding, especially with endometrial mass or thick endometrium.
Yes.
Plus B53, feasible B53 and polymutation. Then go for surgery according to minimal invasive surgery or open surgery according to the circumstances.
Yes. So Ahmed, I'd like to hear someone from our Bahrainian attendees, because I know we have discussed this thing in Egypt several times, and I know you were one of the best. Now you are a teacher. You are not just yeah. So would anyone of our dear Bahrainian friends want to add something?
And I agree also with that point, Basel. Thank you to
Yeah,
change
Dr.
the
Tariq.
time for me. I
Yes.
agree. We have to understand what we are dealing with. And you need a biopsy to understand is it, we have not only endometrial adenocarcinoma, it could be also uterine sarcoma, it could be also something else. That's why we have to be sure. And I prefer also to do a biopsy.
Of course. So exactly. So when you are a general gynecologist and then you put that case in the National Tumor Board, you will hear some saying in the tumor board, why he hasn't done a biopsy? Why would this is? And then you will say, oh, the tumor board is aggressive and they are criticizing all the times and I have done the hysterectomy. It turned out to be serious. I have done my job. I have discovered the case. I have diagnosed the case and I'm referring now for chemo, radio, whatever she will have. So why they are criticizing? Why they are blaming? Okay. Because simply this is not the standard. This will not happen anywhere in the world. Should we have done further imaging? Of course, ultrasound is good, but it will not give you a good or a good picture of myometrial invasion. We need to know how much of the myometrium is the myometrial invaded or not. Is it less than 50%? Is it more than 50%? Is it even going outside to the serosa? The ultrasound will not be so accurate in nodal status, especially in obese women. It will not give you a clear picture about nodal status. And of course, you will not know any distant metastases. Just last tumor board, we have seen a case that was diagnosed like a fibroid, and she go directly to operation with an ultrasound. And intraoperative, they found peritoneal nodules, omental nodules, postoperative, even lung nodules were happen, and the patient was very critical. And now she was discussed in the National Tumor Board. More or less, I'm not going to say this is not accepted, but this need to be minimized as much as we can. Okay, this should be aborted. So MRI, we should do an MRI at least, post-contrast MRI, or if the patient doesn't want to contrast, we can do a diffusion weight MRI to show the degree of restriction of the mass to see the myometrial invasion. We need sometimes CT to know the distant metastasis. So we can do MRI on the pelvis, then CT on the chest and the abdomen, or MRI on the pelvis and the abdomen and CT on the chest. Okay. But mostly we will not need a PET CT. We are now doing the diagnostic guidelines for Bahrain Oncology Center. We are performing it right now, and we stated clearly that in early stage, good prognosis, less aggressive types of endometrial cancer, we don't need to do PET CT. So I'm very annoyed sometimes when I find patients who had got a biopsy, turned it out to be grade 1 endometrioid adenocarcinoma, stage 1A endometrial invasion, and then PET CT was asked for. This is overuse of PET CT. These cases are very rarely to be metastasizing anywhere in the abdomen. Even sometimes in the guidelines, you can go with ultrasound in those cases only, and abdominal ultrasound, but I don't recommend that at all. But PET CT, please reserve PET CT for the aggressive subtypes like the serous, carcinosarcoma, clear cell, or high-grade endometrioid or undifferentiated endometrioid carcinoma. Otherwise, in early stage, grade 1, grade 2 endometrioid adenocarcinoma early stage, we don't need a PET CT. And yes, this is a little entity, grade 1, grade 2, but this is the vast majority. This is majority of the cases that you are going to meet in endometrial cancer will be from grade 1, grade 2 endometrial adenocarcinoma from type A, what we for years have been called type A. The less is the others, the serous, the carcinosarcoma, and blah, blah, blah. Again, don't forget chest imaging, especially in the aggressive subtypes. Don't forget chest imaging. And as Dr. Tarikan and Dr. Ahmed Suidan stated, a biopsy is mandatory before surgery to tailor our surgery. Surgery is not hysterectomy. So you have done your hysterectomy for this serous carcinoma, but really this is what we call inadequate surgery. Yes, you have done your case, but any gynecologist can criticize easily, and he has the right to criticize your surgery because in any post-menopausal bleeding, we should suspect endometrial carcinoma. I should be, when he said to me, it was a surprise. I have just removed the uterus. I thought it was a fibroid. I thought it was like atrophic vaginitis or some sort of endometrial hyperplasia. There was endometrial hyperplasia on my TVS. There was no masses. I say no, because if you go step by step, like what we have learned, any post-menopausal bleeding is suspicious. Not every post-menopausal bleeding is cancer, but is highly suspicious to be cancer, and you must exclude with a pathology. Preferably, of course, with hysteroscope rather than a DNC. Even DNC is not enough, but in limited resources, you can use DNC. I think hysteroscope, even if limited resources, is very available everywhere, even the office hysteroscopy. So again, whenever you are meeting postmenopausal bleeding, you should have a biopsy. It is not accepted at all to say, I got a lady, she is 70 or 65 years old, she is postmenopausal, she had bleeding, and I did a hysterectomy, and whoa, it turned out to be endometrial cancer. This is not accepted. You didn't go by the rules. You should go by the rules. You should biopsy, you should go by hysteroscope, see the endometrial cavity, and have biopsies from that. Again, most fibroids, and you are my dear gynecologist, I'm not a gynecologist, but you know that most fibroids are not going to appear postmenopausal, or they are going to shrink after the hormonal status finished in postmenopausal. So when you find a large fibroid like 10, 12, 15 centimeter in a 65 years old or 70 years old, you should suspect sarcoma mostly or endometrial carcinoma. You can't say it was clearly stated in the ultrasound it's a fibroid, so I went to do a fibroid. No, large fibroids are not common in old age. Yes, we may encounter those, especially with large degenerated fibroids which have been there for years, neglected by the patient, but you must exclude. So not any postmenopausal bleeding is cancer, but you must exclude cancer. Not any large fibroid is cancer, but you must exclude carcinoma and sarcoma, endometrial carcinoma. And any enlarged uterus, you know, the uterus should be small in the old age. So any enlarged uterus, you should suspect that. So if you didn't sample, if you didn't go with a hysteroscope and have a biopsy before, this is not a surprise. This is a mistake in assessing or in diagnosis of the case. That was your hurry to do the case either in the private or the public sector. You want to do your surgery, and this is not good. And this is the most decent word that I say. Because the surgical profile of endometrial carcinoma is not a simple hysterectomy. It may be total abdominal hysterectomy and baltasaphengiophorectomy. It may be that we add lymphadenectomy, either formal lymphadenectomy or at least sentinel lymph node detection. It may be done a surgical staging exactly like ovarian cancer. You should do omentectomy, peritoneal staging, lymphadenectomy with hysterectomy, and don't forget cytology. So simply, when I'm going to do total abdominal hysterectomy and baltasaphengiophorectomy, this is in grade 1, grade 2 endometrioid. Stage 1, node negative, less than 50% myometrial invasion. Those cases, and the good news now is that cases represent the majority, the vast majority of endometrial cancer cases that you are going to face in your practice. They are grade 1, grade 2 endometrioid, stage 1 A or B, no, stage 1 node negative, and less than 50 myometrial invasion. But if we have any nodes positive in ultrasound or MRI, if there is more than 50% myometrial invasion, even in the endometrioid carcinomas, or if you have type 2, which is clear cell, serous carcinoma, carcinosarcoma, and high-grade endometrioid carcinoma, you should assess the lymph nodes either by formal lymphadenectomy or sentinel lymph node biopsy. And again, I want to stop the word lymph node sampling in Bahrain. We have stopped it more or less in Egypt, and I want to stop it in Bahrain. No lymph node sampling. Lymph node, either sentinel lymph nodes or systemic lymphadenectomy. There is no sampling. There is no picking one or two lymph nodes and said I did lymph sampling. So if you have sentinel lymph node techniques, you can go to sentinel lymph node. If you don't, you should go for formal lymphadenectomy. In endometrial cancer, pelvic and para-aortic. In endometrioid, you can go pelvic only. In the other aggressive types, you should go high para-aortic. But again, so if you didn't do lymphadenectomy, simply your patient wasn't assessed well, and after that, she may have radiation unnecessary or chemo unnecessary, or to take her back to the theater, or what we do, we don't know. Okay? So in any serous carcinoma, clear cell carcinosarcoma, this is by default, even in very early stage, even if it is a very small tumor without myometrial invasion, you should do lymphadenectomy. But in endometrioid carcinoma, when it is node positive or more than 50% myometrial invasion, you should do lymphadenectomy. For serous carcinoma, you should go for omentectomy and peritoneal staging. It's like serous carcinoma, the same as ovarian cancer. It usually arises from the fallopian tube, from the STEC lesions, serous tubular intraepithelial neoplasia. This is STEC lesions, the small STEC lesions cause serous carcinoma in the ovaries and in the uterus. That's why we are always removing the tube. If I'm removing the uterus for a benign disease, leaving the ovaries behind, I should remove the fallopian tubes. If I'm doing laparoscopic oophorectomy or removing the ovaries for a case of BRCA positive example patient or something like that, I should remove the tubes. You should always remove the tubes even if you are going to keep behind the uterus or the ovaries. Okay? But serous carcinoma should go treated like ovarian carcinoma with a formal surgical staging, complete surgical staging. You can omit the omentectomy if it is clear cell, just lymphadenectomy is enough. But in serous carcinoma, you treat like ovarian cancer. So the case that we represented, it was serous carcinoma, wasn't managed well. When you represented it in the National Tumor Board, and you said, that's because you should have done omentectomy, peritoneal staging, plus formal lymphadenectomy, pelvic and para-aortic. Like any case of ovarian cancer, as we have discussed, it's a mistake. It's not accepted. And it wasn't a surprise because she was 63 with postmenopausal bleeding. So you should have sampled the uterus either, of course, with hysteroscope or at least by D&C. But I am with hysteroscope, more with hysteroscope right now. Okay. So it was mistake in the preparation of your patient. It was a mistake in the surgical management. This is inadequate management. And this will lead the gynecologist and medical and radiation oncologist to say, no, this doctor have it performed as a good, and this is not good for anyone. We want to do the best for our patients. Okay. So this is the main heart of our operation, to know that for years, since 1981, the year I was born in, the uterine tumors were divided into type 1 and type 2, endometrioid adenocarcinoma. Okay, and anything rather than grade 1 or 2 endometrioid adenocarcinoma is type 2. Okay, type 1 is estrogen dependent, type 2 is not. That's why type 1 comes in the obese, morbid obese patients with hyperplasia in the uterus, while in the endometrium, while type 2 goes on atrophic endometrium. You all know that. This is basic for gynecologists, okay? But those are two different stories with a much favorable prognosis in the type 1 and very, very poor prognosis in type 2, okay? And so this is risk stratification, as we said, according to the endometrial carcinoma, we have gone through this for that. Metastasis can be lymphatic, very common to be lymphatic, more or less can be peritoneal, small portion can be hematogenous only, and don't forget that 20%, almost 1 of every 5 cases will have isolated vaginal recurrence after that. So you should do a good hysterectomy and never a subtotal or near total hysterectomy. You should remove all the cervix with a good vault from the vagina. Again, lymphadenectomy when in grade 3, carcinosarcoma, serous, undifferentiated, mesonephric-like, and gastrointestinal-like mucinous carcinoma. These are new entities, like the last 5 years to be done, mesonephric-like, and we have seen many cases of mesonephric-like carcinomas. In deeply invading tumor, more than 50%, that's why we should do an MRI. And if there is enlarged tumors or even a larger tumor like 5 centimeter or something like that. Okay? Sometimes we can use frozen section as intraoperative guide to tailor for that. That was a paper published by us. It was like a thesis in Mansoura, but really it wasn't incorporated in the guidelines, and the accuracy of doing frozen section is not that high. So you should do a sentinel lymph node, preferably, of course, with indocyanine green. If you don't indocyanine green, you can do it with methylene blue with less results. So that is the common story of endometrial cancer. But again, you meet some cases. We can discuss, Ahmed, at the end, or you want to ask right now? You can say speak right now, Ahmed, if you want. اتفضل يا أحمد. You are not allowed to talk. Just give me 1 second. اتفضل يا أحمد.
Dr. Basil, can we omit MRI, especially if the patient underwent CT staging along with ultrasound by an expert operator?
Ahmed, if this is a case like serous or clear cell carcinoma or something like that, of course we can omit MRI because the surgical procedure will not change. You are going to do the lymphadenectomy anyway. You are going to do the hysterectomy, blah blah blah. But if this patient is endometrioid, which is the majority of cases, grade 1 or 2, you will need an MRI to accurately stage the tumor. The cervical extension CT will not be able to see how much does it go to the cervix, to the parametrium, and the lymph node status, and mainly the myometrial invasion. So if the biopsy is serous carcinoma, you can omit MRI because you are going to do the comprehensive surgical staging anyways. Okay?
Okay.
So, but يعني, let's go to the gold standard for this, for our fellows mainly. Endometrial and cervical cancer equals MRI, okay? Equals MRI. This is the main. Ovarian may be CT, but for endometrial and the cervix, you should do an MRI for the delineation of the pelvis, like what we do in rectal cancer surgery. For us as surgeons, rectum and all the pelvis is better delineated by MRI. And it is the post-contrast. It is post-contrast. If it is non-contrast, it should be diffusion weighted. Okay? So the other stories that I have met like 3 or 4 times now in Bahrain is young age, below 40. Can we preserve the ovaries or not? Okay. Can we remove the ovary or not? This is for the ESGO guidelines. Ovarian preservation can be considered in premenopausal patient aged less than 45 years with low-grade endometrial cancer. So it's grade 1 only, myometrial invasion less than 50%, and no obvious ovarian or extrauterine disease. So
Dr. Basel, can you share the screen?
It is not shared?
Yeah.
Oh, yeah, I'm going to share. Sorry for that. So we can preserve the ovaries if they are patient is less than 45, grade 1 endometrioid carcinoma, grade 1 endometrioid adenocarcinoma, myometrial invasion less than 50%. And again, the good news, those are not few patients. Those are many patients under this criteria. In case of ovarian preservation, as we have said, you should do salpingectomy. If you are going to remove the uterus, preserve the ovaries, you should do salpingectomy. If you are going to remove the ovaries, leave the uterus, remove the uterus. Remove the tubes always. The tubes are the source of evil. Okay, so always remove the tubes. Ovarian preservation is not recommended for sure for patients with cancer family syndrome. Those with BRCA-mutated syndrome, you can't leave the ovaries behind. This is nonsense. And in Lynch syndrome, please remove the ovaries as well. So the good genetic testing should be done before any decision. That's why the decision in gynaecology patient is critical. It is not that I'm going to do surgery rapidly. How I do fertility preservation? If it's diagnosed, and then counseling assessment, the age is young, no risk factors. Okay, I'm still going to see the BMI, diabetes mellitus, hypertension, and fertility wish. The patient should wish to preserve, okay, because this was the standard. So now MRI is a mandatory, Ahmed, to do MRI, to do hysteroscopy, not D and C. I should do hysteroscopy. All the fertility preservation is done with hysteroscopy, not with D and C and biopsy. And then I go to my patient about oncological safety. Okay, this is not the standard of care, but it is accepted. It is found in all guidelines because you have more or less a less aggressive tumor. So we are going to do for you a fertility preservation. This is not lifelong. This was a pregnancy plan. So for example, she should have a partner. She should have some pregnancy plan in the following 1 or 2 years. You can do it for a single patient. If a single patient, you should have a partner within 2 years. And the surveillance, how we are going to do the surveillance, we are going to do hysteroscopy and biopsy every 3 to 6 months. So I'm going to have you back to the theater and do hysteroscopy and biopsies every 6 months. If complete remission happen, and this happens in many cases, you can go for pregnancy, and the pregnancy, of course, is with the reproductive specialist. We are going to Dr. Aisha or with IVF specialist and ask for assisted reproduction. We are not going to wait the normal pregnancy. If there is persistence or progression, we can continue hormonal treatment for another 3 to 6 months maximum. And if not, we are going to do a total hysterectomy. You should be يعني competent enough to say after 1 year of failed treatment, and this happened with us just last month, they failed treatment for 1 year or something, so I should go for total hysterectomy. I can't go for conservative treatment forever, okay? So that's why we should think about fertility. Again, it is not only in fertility preservation, it's with comorbid patients with high morbidity over 70 or something, and then you can, having comorbidity, you can go with conservative treatment. But again, this is when the life expectancy is 1 to 2 years or 3 years maximum. You can do it for a 50 years old patient. So for example, last last month I did a case. She was very high risk for operation. She had Crohn's disease, multiple abdominal operations before, comorbidities, but she was 50 years old. And she had endometrial carcinoma inside. This endometrial carcinoma was managed conservatively for 2 years, but it is progressing. It is still there. I did the surgery, and really a perforation in the rectum happened from us. This is a Crohn's disease, which is very common to have perforations and abscesses formation even spontaneously. And then we stayed together with my fellows in the morning report, and I told them we had complication. Should we go for conservative treatment forever? They said, yes, it would be better. I said, no, because still she had tumor inside, she was symptomatic, and she is still 50 years old. She will not go for conservative for forever. One day she will have the operation. So we have to do the operation with the accepted morbidity and even mortality sometimes because she has a long life expectancy. So yes, we had a perforation which we were not happy with, but this is accepted. And when the final pathology turned after 2 years of treatment to have endometrial carcinoma still there, I am satisfied with my decision. I'm very sorry for the patient, but I'm satisfied with my decision that we took the patient for hysterectomy. She must have do hysterectomy. A very important thing is laparoscopy endometrial cancer. Laparoscopy endometrial cancer is the standard of care right now, okay? Especially in the patients low risk and even high risk sometimes, okay, if you can do the total stage. So again, laparoscopy is not contraindicated in endometrial cancer. It's like cholecystectomy now. If you have a stage 1A, grade 1 endometrial carcinoma, the best for her is to do laparoscopy. So laparoscopy and minimally invasive surgery by ESGO guidelines, by NCCN guidelines, it's like the gold standard, except in some cases where you can do para-aortic lymphadenectomy or you can do something, you can go for open surgery. Okay? So this is again low risk endometrioid simple hysterectomy, endometrioid high risk, you do low risk lymphadenectomy, and in serous type, you should go for omentectomy and peritoneal biopsies. What happened in last years? The story totally changed. It is now not anymore type 1 and type 2. It's all totally changed, like what have done in the breast cancer for the oncologists there. It is now breast cancer, luminal A, luminal B, HER2 enriched, and the triple negative. The same for endometrial cancer. Now we have the molecular classification, so we should have the polymutant types, the mismatch repair deficient, the non-specific nuclear profile, and the P53, which is the most aggressive subtype from that. This is a long story. We are going to have a special lecture about this to try to simplify it for those who are willing, because I know this part, people are not willing to go through it, but this is the standard of science right now. If you are going to deal with gynecology, you must know and you must understand, and I'll have a special didactic for that to try to simplify it. It is very easy for our dear oncologists, I know, but for surgeons and gynecologists, it's difficult. So you should know that the endometrial cancer is divided into polymutant and according to mismatch repair, either mismatch repair deficient or mismatch repair proficient, which we call non-specific nuclear profile, and P53, which if you have P53 mutant, this polymutation is done by NGS, next generation sequencing. However, the MSI or mismatch repair you can do by IHC, and P53 you can do by IHC. And if this P53 mutant, for example, this is خلاص يعني aggressive type and you can omit other things. And we have the multiple classifiers and this is thing. So you should know now it is not type 1 and type 2 anymore. It is the 4 types according to. So if you are going to ask now, and that's what we put in the diagnostics in BOC policy, you don't ask only for histopathology, you should ask for the polymutant status. If you have the NGS resources, you should ask for P53 and MSI or mismatch repair in the IHC. Again, don't forget that the staging changed not last year, it changed in 23, okay? That it is much more complicated now and complex FIGO staging, where it is not 1A and 1B anymore. You divide according to the aggressive or less aggressive pathology. So if it is limited to the endometrium or non-aggressive histological type, it's 1A. So we have now 1A, 1B, and 1C. This is new in the FIGO staging. So I'm not going in details about that, but you should know now that it's very important to know endometrioid is totally different in staging from serous type, because this is aggressive subtype, this is non-aggressive histological type, okay? And a polyp is something, and one of the main changes that if you have low-grade endometrioid carcinoma in the uterus and the ovaries and this synchronous lesion, not metastatic, it's stage 1A. And even this can totally change the adjuvant treatment. And we have one case, like in my first months in Bahrain, I was very happy to meet this case of low-grade endometrioid carcinoma of the uterus and the ovary, and they are synchronous, they are not metastatic. And this is 1A, and she was not to have any chemotherapy or systemic treatment, okay? So 1A, you should differentiate. This is making things difficult for the pathologist because they should differentiate. It is metastatic from the uterus or it is synchronous lesion in the same low-grade endometrioid type. And again, we have the changes according to the lymph nodes. It was strange that for years lymph node didn't change, but now, of course, the lymph node changes it up to 3C if you have pelvic lymph nodes. So again, if you do a case of serous carcinoma without lymphadenectomy, she will have an eventually chemotherapy. You don't know the stage. You don't know it is stage 1A, it is stage 3, and you may tell me that serous will take chemotherapy whatever she is 1 or 3. However, this is totally different story in the prognosis. Okay, and even in the sequence after that in the treatment, especially now we are adding immune therapies, disease, something like that. So it is totally different story for 1A to 3. You should stage your patient. Okay? So lymphadenectomy is very important and integral. So if you can do lymphadenectomy, don't do gynecological cancers, including endometrioid types, okay? Again, this is the ESGO through ESP guidelines of endometrial carcinoma. There is an update in 2025 that I would like you to go all through it. To do minimally invasive surgery is the gold standard. You do hysterectomy, oophorectomy, especially in low risk subtypes. Infracolic omentectomy you see in serous carcinoma, carcinosarcoma, and carcinoma, and ovarian preservation. That is like the sum up of what we have said. So please go to this paper, ESGO through ESP guidelines. This is 2025 update management, and we can have a specific didactic about it, but that what you need to know. Again, this molecular classification changes the whole story to low, intermediate, high intermediate, and high risk, and advanced metastatic. And this would change the story of adjuvant treatment at all in the National Tumor Board. Is it chemo? Is it radio? Is it immune therapy? Or are we going to that? Okay. So now is the era of new molecular classification. We distinguish patients with similar histological features but different prognosis. It guides therapeutic strategies and appropriate surveillance. It is incorporated in virtually every guideline available right now. Molecular directed treatment strategies now are being researched, and that's why in the meeting in BOC we said every case we should do poly, MSI or MMR and P53. Okay, even it has implementation on surgery. This molecular classification is not only the story of oncologists about fertility preserving surgery, ovarian preserving approach, even lymph node to do lymphadenectomy or not. Okay, so it is clear. I don't want to go in details, but if you have a better prognosis, just polymutant, which has the best prognosis, okay, you can do fertility preservation. If it is P53, for example, you will never do fertility preservation. Again, ovarian infiltration is almost nil in polymutant subtypes. Polymutant, you have no. It is highest in P53. It is high in MSI, high preservation. So after very, very few years, like 1 or 2 years, we are going to change the phrase of ovarian preservation not to be done in P53 or MSI high subtypes. You can't remove the ovaries. So I have the biopsy with the molecular classification, and this even can guide and tailor my surgery, even regarding the ovarian preservation or infiltration of the cases. Again, in fertility preservation, if it is Lynch syndrome, if it is P53 copy number high, for example, P53 abnormal, there is no place for fertility preservation. Those are aggressive, even if so early. I'm not going to do fertility preservation for a case of P53 mutant tumor. Okay, so for low-grade tumors, we do the MMR testing. If it is MMR proficient, okay, I'm going to do P53 testing. If it is P53 abnormal, no fertility preservation. P53, no fertility preservation. If it is P53 wild, I can go for fertility preservation. Again, if she is mismatch repair deficient, I'm going to do poly testing. If she is polymutant, of course, has a best prognosis. We are going to fertility sparing, but is poly wild type, there is no fertility preservation. Okay. So again, with high grade tumors, if it is polymutant, you can have a place for fertility sparing. If it is poly wild, there is no fertility preservation. So even the surgeons should know the molecular classification in stage 1 tumors, as you see, stage 1 with hysteroscopic resection. If you see the upper slide, it's a stage 1 hysteroscopic resection. Okay. It is not only the conventional morphology and histopathology, but you should go for the molecular classification. Again, lymph node involvement, I think now you can all say it will be with the P53 abnormal, with the MSI high tumors, much more lymph node involvement. So we can omit sooner or later doing lymphadenectomy in polymutant subtypes, which have the best prognosis, but still this is not guidelines. Those are the future perspectives. Okay. So again, our everyday problems in Egypt and in Bahrain, they are look so similar. I don't feel strange here. Okay. Hysterectomy without proper workup. Do the proper workup, please. The hysteroscopy, the MRI, and the metastatic workup. Hysterectomy without pathology. It is not accepted, especially in postmenopausal females. You can't tell me this is a pathological surprise. Inadequate knowledge about subtypes of endometrial cancer and their effect on treatment plan. Whenever the oncologists are going to speak or the pathologist about the molecular subtyping, I find the surgeons and gynecologists going out to the room to have some coffee or some croissant or something like that. No, you should do it, and we will have a specific lecture on the molecular subtypes and CME or CPD or continuous medical education that we did lots and lots in Egypt, and we are trying to implement now in Bahrain as well. And I hope to see all of you next week in Al Khobar, Meridian Al Khobar. We are going to have our MIMAGO. It's very important. Just cross the bridge and join us in our MIMAGO meeting. You will meet many gynecologists from all over the world, not only the region. And really, it has good CME points, and it would be something good to discuss and to meet you in person. And thank you. So that was my presentation, and there is questions from Dr. Heba Al-Aani. Dr. Basel, we know we have to do endometrial biopsy for postmenopausal bleeding, but shall we do CT or MRI without the histopathology or wait for the histopathology? Wait for the histopathology. I think now it's clear. It's clear what I have said, that the histopathology will totally be different in tailoring your surgery. Your surgery is different. It's totally different story. Serous from clear, from endometrioid type. So MRI is not enough, okay? Or CT is not enough. You should have the histopathology. And Dr. Amani, thank you, Dr. Amani. Thank you, Dr. Heba. Any done. Any more questions or anyone want to say anything? We have
Thank you
more
so
questions.
much for the comprehensive talk, as
Thank you.
usual.
Thank you, Dr. Tarikan. It's a pleasure. So, Dr. Tarikan, for our Egyptian colleagues, he is the head of medical oncology department in Bahrain Oncology Center, and really one of the most knowledgeable and updated medical oncologists I have ever met. Dr. Hisham Abu Talib is asking about therapeutic value of lymphadenectomy. Therapeutic value is questionable usually in lymphadenectomy. You know, Hisham, it is unless there is enlarged lymph nodes, and even those will be managed by radiation. However, for sure, it is very important for prognosis and not therapeutic. Like this is have a therapeutic, but it's going to tailor your adjuvant treatment. And so this is very therapeutic. So you can omit radiotherapy for some patients. You will add chemotherapy for some patients. So it is very important to tailor your surgery and to tailor your future plan. And this is therapeutic, I believe. Okay, but I know that it is the treatment, not in removal of lymph nodes itself. Level of lymphadenectomy, is it affected by molecular classification? Again, we say, of course, in polymutant, sooner or later. This is a promise from me. Before 27, for example, or 28, lymphadenectomy will be omitted in poly mutant, and sentinel lymph node at least should be done in P53 and those. Okay. Do you have poly testing in Bahrain? Now we have poly testing in Bahrain. Dr. Tarikan can answer this question. Amani. Dr. Amani is our pathologist from Mansoura, and she's asking
Yes.
about mutants. Yes.
Yeah. We have it available. We can send it. And available. We sent out this test on. It takes only 1.5 weeks.
Yeah. So it is overseas. It's done overseas, and now we are asking.
Yeah. Overseas.
Yes, but we have the facilities to do it. Okay.
But soon we will have it. Soon it
Yes.
will be in-house. Yeah.
We discussed that, and it must be in-house. This is it must be done for that.
Yes.
Okay. Amani, don't envy us, Amani. Okay, for alternatives of poly NGS, yes, Hisham, there are many IHS markers suggested by our friends in Tunisia, for example, and in Lebanon, but really we don't have evidence for them, and we should try to do the NGS. This is to have the most accurate results. Other alternative types should be validated first before I can say it's okay to do them. They are present, some people are doing it, and according to resources, of course, you can do whatever you want to do according to your resources, but I can't validate it. I can't approve it and say this is the standard of care. I'm happy that there are many questions from the audience. Any other questions? Amira, you don't have question? So, Amira Zidan,
أهلا دكتور باسل.
do you have any questions from Egypt? We miss you really.
Thank you. I miss you too. Yeah, I wanted to ask about completion surgery. What's your take on completion surgery in a case like this?
Completion surgery, like what completion? If it is serous carcinoma already, this serous carcinoma, if the radiology
Yeah.
is free, I'm not going to do any completion surgery because she is going to have the whole combo. She's going to have chemo and radio, okay? So I'm not going to do completion surgery for such case. If it is grade 1 endometrioid, blah, 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 it is really because this is, you know, what starts like, I don't want to say shit, I want to say a decent
Yeah.
word. Yeah.
Don't.
What start like rubbish will continue like rubbish. Okay, so you don't have answers because people are not doing that. But if the patient is going to have adjuvant treatment anyway, and the adjuvant is combo, chemo plus radio, I'm not going to take the patient back to the theater.
So the
Doctor,
effect of the effect of chemoradiotherapy is the same as the effect of chemoradiotherapy even if we do the completion surgery or the complete
yeah, and
surgery.
even the effect of radiation alone on the lymph node is more or less equivocal to lymphadenectomy if there is no bulky nodes in the pelvis. So radiation, if the patient is going to have external beam anyway, I'm going not to take the patient back to the theater.
Okay, and one more question. Thank you. If when we take the sample from the hysteroscopic biopsy, we send that also for immunohistochemistry, صح? Molecular marking.
Yeah. From the start, you should know now. You should do the poly, the MSI, and the PQT, whatever is available for you in you should do in the preoperative biopsy. And there is concordance. There is concordance. What's found in the biopsy usually is the same what is found in post-hysterectomy specimen, but you have earlier clear story. Yani.
Okay. Thanks, Dr. Bassel.
Thanks, Dr. Amira. Dr. Wadia Gibral, just if you can clarify this point, in case of fertility preservation, we can wait for 1 year before going to hysterectomy if no pregnancy or in case of progression. So, Dr. Wadia, again, the fertility preservation, we will have a special didactic on fertility preservation in all gynecological cancers. But if we are doing fertility preservation, we are going to put a Mirena loop and give progesterone orally. Okay, this is the standard of care to give insert a Mirena loop and progesterone orally. But the profile is maximum 2. Some people extend to 3 years, 2 to 3 years. I can't go for this for further than 2 to 3 years. So if the patient had complete response and she is not pregnant or she doesn't have a partner or something, I can leave her the window for 2 to 3 years, but not after that. And really, I had more than one patient who didn't have a partner. She had complete response. And she didn't get a partner for 1 or 2 years. And then I said, I have to remove the uterus. And she said, no, I'm still 38. I'm not going to remove my uterus. And now I'm disease free. You said the hysteroscope is free and the biopsies are free. So how I'm going to remove? I said, I don't know, but I don't have any evidence from the literature to go beyond the 2 to 3 years of conservative treatment. And really, this patient, after that, developed the recurrence. In hysteroscope, after that, we had a recurrence, even with synchronous lesion in the ovary after that. So it is not safe to keep your patient on conservative treatment for more than 1 to 2 years, okay? If there is slight disease progression, of course, a slight disease, because we are speaking about an early disease, or persistence, you can continue with systemic treatment with Mirena loop and progesterone for other 6 months. If it is still progressing, so it is not responding, you have to remove the uterus, okay? Or it is rapid progression or something happening, you should have. So the threshold for doing hysterectomy should be low, okay? Is it clear, Dr. Wadia? I'll open the mic for you, Dr. Wadia. Yes. Okay. It's clear. Any other questions? We have No, just Dr. Wadia. Okay. Thank you and see you next week, inshallah, before the Mima Go. And I hope to see you all in Mima Go in Al-Khobar, Meridian Al-Khobar, inshallah. Thank you and good night, all.
Thank you so much.
Thank you, Dr. Tariq Kanri. Hi, thank you. Bye-bye.